Lee, I would love to sort of ask you about accessibility of these medicines. In some of our previous discussions, we've talked about the cost of goods relating to clean rooms. Let's hear your perspective on this.
Yeah, this is the number one issue, right, for cell therapies right now, and cell and gene therapies. It's been fascinating to watch the evolution of our understanding of this problem, and the importance of it. I would say 3 years ago, patient accessibility was a sort of a nice to have. People were thinking about it, but not really vexed about it necessarily. These were highly curative therapies. We just imagined that, if you can prove that you can cure people of uncurable disease, everybody will want to help deliver it, right? And that's the assumption of all great innovators, right? They assume I've created this wonderful widget, everybody will get it, and everybody will want it, and everybody will buy it. And oftentimes that's sadly not the case for very practical reasons. And I think, last year, I think the light bulb started to go on where people were starting to realize, we started to see the sales of CAR T cell therapy starting to flatten. And we were mystified, right? Like, why? Like, suddenly we were like, why doesn't everybody want to use this? And so we started to unpack that a little bit. And I would say going into 2026, the number one hashtag on everybody's lips is patient accessibility, right?
Yeah.
We have, not surprisingly, a highly correlated association between about 20% of cancer patients treated in advanced medical centers and 80% treated in some level of community healthcare. And the flattening of CAR T cell therapies at about 20% of eligible patients.
Okay, so the patients where they are close by are the ones who are getting it?
Right. And or the wealthy, or the people who are highly committed, to relocating for the amount of time it takes, right? If you think about how it looks today, if I live 3 hours away, 4 or 5 hours away from the closest advanced medical center, I'm super sick. B, I hate going into the city. I don't have money to live in the city for 3 weeks. I don't have family there, whatever. And my family all has work. They can't. I can't have just a support system to relocate with me to get me to and fro. That doesn't look like an attractive option at all, right? Even if you were able to consider it, some people. And so you see data now showing that even of the eligible patients where they're eligible for CAR Ts, a lot of times patients will, and in consult with a referring physician, decline it, because practically speaking, it's impossible to access, right, for them. And so unless we're going to move to a model where we're going to finance the relocation of every patient to an advanced medical center, which might make sense in ultra rare disease, but if you've got larger indications where you want to access that 80% of cancer patients that are being treated in a community healthcare setting, and you've got referring physicians that don't really understand CAR T, or they're worried about losing the patient, or what that looks like, we have to figure out how to bring those therapies to their community hospital setting.
Yeah.
Right. And it turns out, operationally that's a lift. Financially, that's complicated. The insurance companies, have set criteria for the kinds of facilities that are able to deliver CAR T cell therapies, and that they will pay them to do so. And the community healthcare settings find it challenging to check all those boxes. And so, what we know is unlikely is that we create advanced medical centers in every community healthcare setting that we need to treat these patients. And so those of us that are really thinking about this have come to the conclusion that the operational infrastructure to deliver CAR T cell therapies in the community is unlikely to be a cookie cutter of the vertically integrated operational infrastructure that exists in advanced medical centers. And so how can we support the delivery of these CAR T cell therapies in community or outpatient settings using a different model of infrastructure and operational service solutions that can be effective and safe, but is appropriate for the community level, right? And a lot of that requires financial administrative engineering, also contractual engineering. But these kinds of technologies that we're talking about are also going to come to play to the extent that we need decentralized or local capacity at small scale. We definitely now don't want to have to rely on cleaner infrastructure or highly skilled technicians to be able to handle these products, right? Even if that's not decentralized manufacturing, even if it's just, apheresis, that's close to the patient, lymphodepletion that's close to the patient, post-manufacturing, but pre-infusion processing that needs to happen, right? The pharmacy, oftentimes the cell therapy lab at the hospital will accept these products, store them, thaw them, do whatever processing needs to happen in order to deliver it up to the ward for infusion. At these community hospital or outpatient settings, they don't know what to do with these kinds of products. They've got no experience. They don't have a cell therapy lab. The pharmacy has no experience handling these kinds of products. And so what can you provide in that setting to be able to give them the comfort and the operational capacity and capabilities to be able to do that if it's not in the hospital?
Okay, and it sounds like contained box-based systems are one of the sort of physical approaches to this, aside from the administrative requirements and the others.
There are certainly some companies who believe that decentralized manufacturing is the way to crack that nut. Just to locate manufacturing close to the clinical sites wherever you need to do that. And Galapagos is an example of that. They're convinced that that's the only model that will work, especially outside of Europe and North America, where you need logistics are even more complicated and costly. In order to be able to provide access to patients in poor settings, you're going to need the manufacturing close to the clinical site. In addition, of course, they also believe that a fresh product is way better than a cryopreserved product, and so that also compels them to want to do close manufacturing. But put that argument aside, and be agnostic as to whether or not decentralized manufacturing is going to work for you. For autologous cell therapies, you want to require the least amount of travel possible and discomfort and relocation for the patient as possible. And provide what you can locally, right? So there's no reason why we can't provide local apheresis, right? There's no need for the patient to have to travel 3 hours to the middle of the city to an advanced medical center for an apheresis. We can roll up an apheresis machine. We have lots of apheresis local capacity. If it's cryopreserved, we can have regional cryopreservation of the product, and you can ship it to a centralized manufacturing facility. And then we want to relocalize. We have local the other steps, right, that are close to the clinical site. So lymphodepletion does not have to be done at the advanced medical site, right? I think we're moving toward imagining, being able to lymphodeplete, where the patient is, and then, ultimately have the kind of post-manufacturing capacity that's able to, accept the product, store the product, control thaw the product, do any processing needed for pre-infusion local, and then even start to infuse these products in outpatient facilities that are proximate enough and have a close enough relationship with capable hospitals to deal with adverse events when they happen, right? And now that we're seeing, we're understanding cytokine release syndrome much better, and the adverse events are much more infrequent, much less serious when they do happen, and our ability to treat them when they do happen is much evolved. I think the ability to be able to infuse these in outpatient facilities and provide them with advanced medical support when and if needed is a much better paradigm for patient care and patient accessibility.
All right. Well, as promised, this is just going to be a teaser. So stay tuned for the next conversation where we dive more in depth into the next frontiers of cell therapy including distributed access for patients outside of major medical hubs like Boston.
Awesome. Thank you, Nicholas.